Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss the importance of political advocacy in urology. Joining me today for this discussion is Dr. William G. Dr. G spent his career in private practice in Lexington, Kentucky. He was president of the AUA in 2016, and from 2005 to 2009, he served as treasurer of the AUA. He has held numerous leadership positions, including president and secretary-treasurer of the American Association of Clinical Urologists and president of the AUA Southeastern Section. He received his medical degree from the University of Wisconsin School of Medicine and Public Health in Madison. He did his urology residency at the University of Washington in Seattle, which included a year as an NIH Senior Research Fellow. Additionally, he served 2 years on active duty as Lieutenant Commander, Medical Corps in the United States Naval Reserve, which included service in Vietnam. Dr. G represented the AUA as a delegate to the AMA House of Delegates prior to becoming AUA President-elect. In addition, he served as the AUA representative to the RUC. The RUC is the AMA Relative Value Update Committee, and he did this for over 20 years. The RUC determines the relative values for the Medicare fee schedule. Over the years, Dr. G has served on numerous AUA committees, including Urology Core Curriculum, Investment, and Future Urology Residency Training Task Force. He's also been chair of the AUA Health Policy Council and has testified before Congress on urology issues. In addition, he served on the Aetna Insurance Company National Physician Advisory Board for 14 years. Dr. G's AUA awards include the AUA Distinguished Service Award, the AUA Presidential Citation, and the AUA Lifetime Achievement Award. He has been a member of the AUA since 1980, and he was awarded an honorary AUA membership in 2011. Dr. G, thanks for joining us today.
Well, thank you. It's good to be here.
Let's start from the beginning. Sometimes urologists don't know where to start with involvement in urology advocacy. Could you share how you became interested and involved in urology advocacy and tell us how you got your start?
Yes, I didn't start right out with advocacy. When I got my boards at that time in the Southeast section, which is the section in which I live, you had to go get an interview, and I had passed my boards, and so I had to wait 3 years, and then which was the rules in the Southeast section, because it was not unified. Each section had different rules. And I had to go to Memphis on a rainy day and get interviewed to see if it was okay if I joined the section. I was interviewed by a urologist who was sitting smoking a large cigar and seriously blowing smoke in my face. And anyway, I passed his test, which he asked. He said, "Well, I was in the Army." I said, "You were in the Navy?" I said, "Yes." He said, "Oh, that's good." And that was that. And that kind of frustrated me, because I started looking at other sections, and I saw there was one section where you could join right away and not have any interview. And I saw other sections you could join in 1 year. One section took 4 years to join. And so I contacted the AUA about this. I didn't know much about the AUA at the time. And I was given to a woman named Jean Robinson, who was involved in membership. And I told her that this really frustrated me. And I said, I'd like to find out what the rules are in every section. So I worked with her over a period of months, and we made a big table. And it showed each section and how the requirements were very different before you could join. And so anyway, this was written up and was sent to the board of directors. And this became known as the McGee report instead of G. They thought my name was McGee. And this led over the years to standardizing and getting people in the AUA. And I thought that, well, it's a responsive organization. And so that led to me getting more interested in the AUA. Then in about 1987 or 88, I was in my clinic office on a weekday seeing patients. And my people in the office said, well, somebody from the state government just showed up and they want to inspect our office. And I said, what's that all about? And people came in and what to do. And they went through the office. And apparently a disgruntled employee had said we did not have an eye wash fountain in our office because we mixed BCG up at the time. Now, an eye wash fountain is actually just a standard spigot on a wash bowl or on the water of a sink. And it's a little thing that you can push a button and the water will shoot straight up. They also said we didn't have any poison stickers on the waste baskets in the treatment rooms. Well, I thought that was kind of crazy. But anyway, we got fined $5,040 by the state of Kentucky. And I then found out that I didn't have to really let them in the office. I could have told them to leave and make an appointment. But anyway, that kind of frustrated me. And I said I wanted to fix that. And we talked to our lawyer. And our lawyer said, well, for $5,000, you're going to spend more in legal expenses. It's hard to deal with the state. And you ought to just pay it and suck it up. So we did. And then in 1988, I met a couple of other young urologists at an annual meeting of the AUA. And I also met some people with the AACU, which was the only advocacy thing for urology at the time. The AUA, that was 1988. The AUA didn't do advocacy. So I got involved with the AACU, and it's a small organization, but we were interested in getting Congress to involve things in Medicare and that sort of thing. And then I want to say when Dr. Logan Holtgrew was president of the AUA, that was at the 1993 meeting, and it may have been in Nashville. I'm not sure. He had seen the McGee report, as it was called. And he said, well, that was very interesting. He said, would you like to get involved in the AUA Relative Value Update Committee that just started? And I said, well, sure. And another urologist named Greg Slakta was doing that at the time. And Alan Bennett, another urologist, Alan had been in New York State, were involved in it. And I said, sure. So I started going to some of these meetings in 1994. The RUC started in 1992. And that was when the Medicare fee schedule got introduced and all the fees went down. So anyway, I started doing that. And I got involved in relative values and all that sort of thing. And then one thing led to another. And at the time, Joe Corriere, Joe Corriere and I, because I was involved in health policy, were invited to go to the AUA Board of Directors meetings. And that was in the old building in Baltimore on North Charles Street. And I remember several of the meetings, we'd bring up things about socioeconomics, or there were problems with this or that. And the president at that time of the AUA and the board in general said, well, we don't talk about money here. We don't talk about things like that. We do science. So anyway, one thing led to another, and I got more involved, wound up going to Washington, D.C., and found I had a talent for that, I guess. And I've talked enough here, and why don't you go ahead and ask me something else?
Well, so there's a couple of really cool parts of that story right there. So during your interview process, what was it about that bothered you enough to generate the McGee report?
What bothered me, I had a good friend, met John Fracchia, who's retired now, as a urologist in Manhattan. And John truly had a Park Avenue practice. He was his office was on the corner of Park Avenue and 72nd Street. And John, and I talked to him, and in the New York section at that time, as I believe that was a section, you could just join the AU, you passed your boards, and then you joined. And at that time, you had to belong to the section. You had to join the section first to join the AUA. And I was just frustrated by it. And that was what prompted me to look into that, and wound up making this table of all the different sections, and each section had totally different requirements, and that's what led to that, was a frustration of having to wait 3 years after I passed my boards and all that to join organized urology.
So I'm going to call it the G report, because that's really what it was. So did the G report result in a standardization amongst the sections on how things were done?
Yes, eventually it did. The board took it under consideration. Jim Gallagher was the CEO of the AUA at that time, preceding Mike Shepard. and actually, I took the McGee. That's right. I took my report, my paper report, and I took it to the AUA meeting, and it may have been in Memphis, I'm not sure. And they had a health policy sort of a meeting. Jess Reed, who's now deceased, was involved in health policy. And I took it there, and at the end, up where they were, I just left it on the table. And I got a phone call from Jim Gallagher a month later, and he was going through things from the meeting, and he asked where that came from. And I said, well, I did it with Gene Robinson, one of your employees, because I was trying to find out why it took me so long to join the AUA and some other people could join faster. And he then took it to the board of directors. And then it took a period of years for this to actually change, because, sections, some thought it was important to have interview. Anyway, that's all changed now.
Another question for you. So during that episode, when the state came in to inspect, what did that lead you to change in your practice?
Well, first of all, not to let anybody in from the state without an appointment, and secondly, it just showed how silly that was. They could have said you need an eye wash fountain, which would have been fine, and we would have done that. And we wound up putting these skull and crossbone stickers on all of our waste baskets, which is really, goodness. And we got fined. And it just was and we never got inspected again. Nobody came back to inspect to see if we had corrected these things. There was no follow-up on it. And it was, still don't know why they came up. I imagine it was an employee, but we tried to figure out where it came from, never could.
Interesting. All right, well, let's switch gears. So how is advocacy for medical specialty like urology different from what the American Medical Association does in Washington?
Well, what urology does, what we do is try to advocate for our issues. So PSA testing, advocating for physician ownership of back a number of years ago for shockwave lithotripsy, things like that. We advocate for issues that are pertinent to urology. The AMA does more global issues, and they deal more with the although we talk about the Medicare fee schedule, they are the ones that actually do the most important work on that. So they have a more global thing, and then they also represent all the specialties. So all of the specialties are involved, and in the AMA House of Delegates has about 500 delegates. And the number of delegates a specialty has depends upon the number of the specialty's members that belong to the AMA. So we have, urology has 3 seats in the House of Delegates, 1 from the AACU and 2 from the AUA. Some other specialties, the surgical specialties generally don't have many representatives. primary care, I think, has, I don't know, goodness, they got like a dozen representatives. But although urology or another surgical specialty may be a small voice in the House of Delegates, we use the House of Delegates for some of our specific issues. And one of the issues that we had was and I want to say it was about 2011, perhaps, the USPSTF, the United States Preventative Services Task Force, that issues all sorts of recommendations, came out and said that PSA, they gave it a D recommendation, which meant there's no reason to do it at all. And so the urology delegation, the three of us, we got up and spoke about how it was important to do PSA testing and talked about all of this. And the main opposition was from internal medicine, and their representative, a woman from the Mayo Clinic, said it was absolutely unnecessary to do this. It led to unnecessary testing and unnecessary surgery and things of this sort. But we managed to prevail, and we got the House of Delegates to vote overwhelmingly to tell the USPSTF that they thought this was bad medicine and this was wrong. And it didn't change right away, but then in, I want to say 2018, perhaps, the USPSTF changed their recommendation to a C rating. And the C meant that that you could do testing after explaining it to the patient, and it's much like the guidelines that we have in urology now. But that was one point where advocacy, urology advocacy done through the AMA and getting all of the other specialties to support our recommendation definitely helped to do this.
Yeah, and the ramifications of that effort were huge, because I believe that if it would have kept as a D rating, insurance companies could have elected not to pay for PSA testing. Is that correct?
That is correct. That is exactly right. And so, but I think it took from 2000, well, it took about 7 years for them to change. And in that time, of course, then the AUA did our own lobbying about PSA testing with Medicare and the federal government. And now, of course, it's covered by Medicare. And to add, what Medicare, the Medicare fee schedule, although it just applies to Medicare, and what the RUC committee does is just for CMS. All of the private insurance companies use the Medicare fee schedule, and then however many relative values are for something, then they may have a different conversion factor. They may pay for a particular contract. They might pay 17% of them, more, 117% of the Medicare fee schedule. So, and it includes all the different specialties. Every CPT code in the book for pediatrics, psychiatry, surgery, orthopedics, urology, allergy, all of them are affected by this. So it's where the rubber meets the road as far as reimbursement. And the RUC is still going on. I believe I'm going to my last RUC meeting next week. I in Chicago. The RUC meets 3 times a year for 3 or 4 days in a hotel, twice in Chicago, once in the winter, usually in Florida or Arizona. And there are about 300 people who attend. There are 27 permanent seats on the RUC, of which urology has one, was since the beginning in 1992. And we present new codes and defend old codes. There are all sorts of rules now that codes have to be reviewed every few years. A particular code that gets used, suddenly the utilization goes up. You have to defend that and resurvey it. So, and I've done the RUC on and off I did it back then, and then when I became AUA treasurer, I didn't do it, and then I went back and forth, and that sort of thing.
Well, it's super important work. We all benefit from your efforts to defend our codes and reimbursement for sure. Most people know that the AUA meets yearly and comes up with some advocacy, some important key points, and then from each state, people go and kind of stomp the hill. Can you tell us what some of the more recent advocacy points that the AUA has emphasized and worked on?
Well, their list is made up, and it's usually a 10 or a dozen things, and some of them are global, like physician reimbursement, and some of them are specific, relating to things that have to do with urology, such as we discussed PSA testing. It often involves the cost of, we know that the cost of running our offices has gone up, and part of the Medicare fee schedule involves what's called the practice expense. So as we know that the cost of employees goes up, the cost of supplies increases. And so we've lobbied about having, when we lobby for that sort of thing, we're really lobbying them to push CMS. Is what we're doing. Those every year there are some things that are always on the list, such as reimbursement. Other ones have included radiology pre-certification for CAT scans, and the time it takes physicians sometimes to get approval for drugs. If you wait, you have to have somebody get approval for a particular drug you want. That has actually improved some. That Congress has really helped with that. But those are things, and then we go with specific examples from urology for a drug that may have trouble getting reimbursed. And it's good when one goes to talk to the representatives to have a specific example from your own practice, where you had somebody who, we have the PET scans now and other things that are useful in some patients. For example, with urology, with prostate cancer, and some problems getting approval to do this. And the interesting thing about that is that 95% of the time they approve it. I mean, it gets approved, but it's these hoops that you have to jump through that make it more difficult and use up your employees' time and raise the cost of running your practice.
Right.
So it's an important thing to do, and getting to know, if you can, and this is important in the state now. So we're talking about nationally, getting to know your member of Congress if you can, and personally giving your member of Congress some money when they're running for re-election, you give them $100 or give them $500. They remember that. And believe it or not, we have as somebody said, we have the best Congress money can buy. And that's the fact. That's the fact of the matter. Urology is a small specialty, but we deal with some very important issues. And members of Congress know this. They want to help you. And now on the state level, there are different issues because different states have, as we know now, very different issues. And it's important to get to know some of these politicians over the years if you have a chance to do that.
So you brought up an interesting point. So regarding the practice expense, I was doing a podcast earlier, and we were talking about that after COVID, the cost of employees is up about 23%. So how receptive is Congress, or are the AMA, how receptive are they to hearing that a practice expense goes up 23%? I mean, what's their response to that typically?
Well, again, the response has to come from the RUC committee. That's where it comes. And so practice expense, for every CPT code, there's a very detailed Excel spreadsheet with how many minutes of employee time, literally how many pairs of sterile or non-sterile gloves are used, if a syringe is used, if needles are used, if IV tubing is used. For urology, we have a thing called a cysto package that contains the number of different things that are in it. And then the employees, there are Medicare determines what the cost is per minute for a registered nurse, a PA, a medical technician, a radiology technician. They have prices on those, actually, how much per minute the cost is. And Medicare again is of course, we hear out of money, and the Medicare budget, they're trying to keep it from going up. And so the AMA and the RUC committee push to get these things increased. And it used to be, when I was first involved with this 30 years ago, or 1994, I guess, 94, 95, about over 95, 98% of what the RUC recommended, Medicare approved. They said, okay, that sounds good. Now it is about 85 to 90%. In other words, they don't always do, like we can go to the RUC and for example, laparoscopic radical prostatectomy, and that includes robotic assisted. There's not really a separate code for that. That particular procedure has, originally the open retropubic prostatectomy for years sat in the CPT book. It had 12 post-operative visits in the hospital. And then things got better and urologists got better. And now we know that in some cases, people can even go home later the same day if they have a successful robotic prostatectomy. But you're getting paid before, when the patients were in the hospital, you get a CPT code proxy for each post-operative visit. So, and it might be a hospital visit, a 99203 perhaps, in other words, for a level 3 visit. And so you have all those visits. Well, all of those get stripped out. So the reimbursement goes down because you're not getting those visits. And of course, it's a 90-day global procedure, which means everything is covered in the fee. And this has happened not just to urology, it's been happened to many specialties. Orthopedics, they're now doing total hips with an anterior approach that sometimes people, it takes a day. And those people used to be in the hospital for a long time. And so now they go home and they have somebody come to their house for physical therapy. And that's in a different sort of a coding area. So it's just very, as times change and things change and reimbursement goes down. And the government claims they're out of money. And I think if you watch television, you probably can figure out that they are.
How would you touch on an important point about relationships with, local, state, and national politicians? How does one develop or start a relationship with a politician?
You go meet them. You try to meet with them in where you live. because they all have offices in your community, or if you're in a state that only has big geographic state, it's more difficult. But you want to try and go meet with them sometime, and they'll meet with you. It's harder to meet with a U.S. senator unless you're giving them money. Seriously, right. Unless you're like giving them a check from a political action committee, for example, then they're more more receptive. But no, and most politicians I've found they really want to do a good job. I mean, they're trying to do a good job, and they don't like to irritate physicians. They like to be friends of doctors. Now, and as an example, and I don't really know Mitch McConnell, but a number of years ago, Urology was trying to get a bill through Congress called the Euro Trauma Bill. And because of the injuries in Afghanistan and in Iraq caused genital injuries, not only for men, but for women as well. And for 6 years, the AUA was trying to get this done. Every 2 years, you have to reintroduce a bill in Congress. It expires and you have to do it over again. And so we had about 30 or 40 members of Congress that would sign on to this, but it would never go anywhere. And what the bill wanted to do, as I recall, it asked for like $50 million, which isn't very much money in the great scheme of events, to get the VA and the Department of the Army to sort of talk to each other and work with urology to study and look at urologic trauma. And we weren't getting anywhere. And then we got the idea to go talk to Senator McConnell, who was it was 2013, and he was the leader of the majority party at the time, and so a very powerful guy. So went to Capitol Hill and sat down with him in his office and explained this to him. And he thought it sounded reasonable. And then he said, well, he said, we've got the defense authorization bill coming up for I don't know how many $1 billion. And he said, well, I'll just add it on to the authorization bill. And he did. And it passed. I mean, like with, he tweeted out, the only time I've ever had a picture of myself tweeted was Senator McConnell. He tweeted a picture out how he had helped the veterans and the urologists treating urologic trauma.
That's a great story for sure. I've heard of other ways to engage politicians is larger groups will have like kind of a donation party where they'll have them come in and, each person gives a minimum of $250 or $500. And that's a way to interact with them too. The other thing that I've heard is effective is when, you're representing yourself or a group, when you meet them, you say, I represent, 500 patients, or I see 500 patients from these zip codes, which are all part of your constituency. Yes. And that tends to get their attention as well.
Yes, that's good. That's a good point. And they all want to get reelected. We know that. So they're right. very sensitive to that.
Well, let's talk about 2024. Given the current environment in the urology specialty, what do you see as the biggest challenge that may affect advocacy efforts?
I think one of the way we all practice medicine has changed dramatically in the last 30 years, 40 years. We've gone from some physicians in an academic practice who are separate from the community. And back when I first started to practice, there were small practices. We were all separate. Well, as we know, bigger, some people think bigger is better, but bigger has become the way things are. And now I believe roughly 25% of urologists are in large practices. Whether they're academic practice or they're in a corporation practice, urologists have come together in large groups And as a result of this, they look to the group to advocate for them. And as we know, hospitals are buying practices, and physicians come out of urology residency, and some of them go to work for large hospitals. So they say, well, the hospital does my billing. The hospital takes care of me. My group takes care of me. So I think that one of the, not just for urology, but for other specialties, one of the big dangers is that as this happens, and urology practices and other practices become more and more involved with these large groups, that the physicians are away from the business of the practice. And I can certainly understand people want to just practice medicine or practice their specialty, but it is so then they're not involved with it. They're not involved. I think that is the biggest threat that we see today. And I look at the AMA House of Delegates about, and the numbers are, I believe about 14 or 15% of all physicians in the United States belong to the American Medical Association. Yet it still is the one organization that Congress and Medicare turn to first when they have a question about something in medicine. And as far as urology goes, not all urologists belong to the American Urological Association, in spite of the fact that there are residents and training belong to it, but then they have to make a positive effort to join the AUA. And I should have looked up. I believe about 92% of all board certified urologists are members of the AUA, and that includes senior members who are retired. But not all urologists are members of the AUA, and that's the thing that has frustrated me over the years. I've given talks at meetings and tried to tell people, among other things, the AUA does this, but not all, and I don't understand that. And I know the residency program directors try very much to to get their residents feeling that we're a small organization of how many urologists are in practice, 11,000, 12,000 urologists, something like that. When you look at other specialties like the hospitalists, I'm told, may become the largest specialty in a few years, bigger than primary care, 100,000 of them. So that's what we're competing against. But it's a problem to get people to get involved. But some people like to be involved, and the AUA Advocacy program that's held in Baltimore. It's fun. You get to hear some interesting speakers and go visit some interesting people, and it's take a couple of days off from your practice. Take your wife with you if you want to go there. Go out to dinner in Washington D.C. But going through just getting the experience of going through the Capitol, going through the different House office buildings or the Senate office buildings, and really seeing how big our government is and how it works and how you can become part of it. And that's what you're doing. You're really becoming part of it when you go there and do that. And you may figure, well, I was waiting to see my congressman, and they had 5 guys there with cowboy boots and cowboy hats, and they were from the Oklahoma oil and gas organization. And they're leaving, and you're going in, and then after you, there's another group. But all of these things are important, and if you're not there, as somebody said, if you're not at the table, you may be on the menu, and we don't want to be on the menu. We want to be at the table.
Yeah, I would strongly endorse what you just said. That's going to the advocacy committee has been a great experience. I've done it several times, and it's not only fun, but it's really kind of intellectually stimulating to see how the government works. And you also feel like you have a voice. So I would strongly recommend that all the listeners out there that haven't done it should go to the meeting for sure. So, well, Dr. G, we've covered a lot of ground today. Thank you for sharing your time and expertise with us today.
Well, you're very welcome. I hope if somebody listens to this podcast, which I know many will, I hope this may stimulate them to get involved, because just sitting aside and complaining about things doesn't get it done. You have to get involved.
Absolutely. And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand, unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.